One of the biggest challenges in diabetes care isn't just about managing blood sugar right after a meal. It's about all those quiet hours in between, overnight, between lunch and dinner. That's where the real test is. So today, we're going to dive into the workhorse medication that really masters this challenge, intermediate-acting insulin.
Right? That's the big question, isn't it? It's not about that quick sprint of coverage for meal. It's about providing a steady, reliable, background level of control. And the answer to this constant need for stability is exactly why this type of insulin is so incredibly crucial in our day-to-day practice.
And this is it. This is our guy. Intermediate-acting insulin's whole job is to provide what we call basal, or background coverage. Think of it like the steady bass player in a band, just working tirelessly behind the scenes, keeping those glucose levels stable when a patient isn't eating. This slide just lays it out so perfectly. On the left, you've got the sprinter. That's your short-acting insulin, built for a quick, powerful burst to handle the food that just came in. But on the right, that's our focus, the marathon runner. It is literally engineered for endurance, providing steady, long-term control for a good 12 to 18 hours. And that means fewer injections and a whole lot more stability for your patient.
Okay, so we get it. It's the marathon runner. But how does it actually run that race inside the body? I mean, to use it safely and effectively, we really have to follow its path from the moment of injection all the way to the end. So let's take a closer look at that journey.
All right, so for NPH, which is the most common type you'll see, the journey is pretty predictable. The onset, when it first starts working, is about 1 to 2 hours in. The peak, which is its moment of maximum power, hits somewhere between 4 and 12 hours. And its total duration, how long it hangs around, is 12 to 18 hours. And you might be wondering, why intermediate? Well, it's because the insulin molecules are actually bound to a protein. The body has to break down that protein first to release the insulin, and that's what creates this cool built-in delay in extended action. And listen, if you remember one single thing about that timeline, make it this. The peak is the danger zone. I really want you to lock in on those hours, from 4 to 12 hours after you give the shot. This isn't just when the insulin is working, it's when it is at its absolute strongest, creating the single biggest risk for your patient's blood sugar to just plummet.
And this is exactly what you are hunting for in that danger zone, hypoglycemia. You have got to be able to spot these signs instantly. Sweating, shakiness, confusion, maybe they're just not making sense, and this profound weakness. Recognizing these early is a fundamental, absolutely non-negotiable safety skill.
So, knowing this huge risk, what's your role as the nurse? How do you proactively protect your patient? Well, it all starts with flawless, safe administration. Before a single drop of that insulin even enters the syringe, this safety checklist is mandatory. First, check the blood glucose. You never give insulin without knowing your starting point. Second, you confirm your 5 rights, especially the right insulin and the right dose. Third, for NPH, you gently roll the vial to mix it. And finally, you give it on schedule, because with this stuff, timing is everything. And here is a crucial pro tip, a little pearl of wisdom you will carry with you for your entire career. NPH insulin is supposed to be cloudy. That's normal, because it's a suspension. To get a nice, uniform mixture, you have to gently roll the vial between your palms. Never, ever shake it. Shaking creates foam, and that can lead to an inaccurate dose. It can even damage the insulin protein itself, making it way less effective. Just remember, roll it, don't shake it. The how is critical, but so is the where. You have to rotate injection sites with every single dose, using the approved spots like the abdomen, the thigh, or the upper arm. And here's why this is so important. Injecting in the same spot over and over causes something called lipodystrophy. Basically, the fat tissue under the skin gets hard and scarred. That scarred-up tissue has terrible blood flow, which means any insulin you inject there will be absorbed erratically, or maybe not at all. And that leads to dangerously unpredictable blood sugars.
Okay, the needle's out, the Band-Aid is on, but your most critical work is really just beginning. Now, you shift into the phase of vigilant monitoring. So this becomes your mental checklist for the next 12 hours. You're monitoring blood glucose levels according to your facility's protocol. You are actively on the lookout for any sign of hypoglycemia, especially as you get into that 4 to 12 hour peak window. You're meticulously documenting everything, the administration, the patient's response. And you're always thinking ahead. What's the timing of their next meal relative to this insulin's peak?
Beyond your direct actions, giving the shot, monitoring, there's another powerful layer of safety you have to build, and that's empowering your patient through education. And this is where you go from being just a caregiver to being a coach. You can see it here. This is a true partnership.
When you teach the why behind consistent timing, the patient gets why it's so important to take it on schedule. When you connect the dots between the insulin peak and their meals, they understand that skipping lunch isn't just about being hungry, it's a serious safety risk. You're building a team, and the patient is the star player.
A critical piece of this coaching is equipping them with their own personal hypoglycemia safety plan. You've got to teach them to recognize their own early symptoms, to always carry a source of fast-acting sugar, to treat those symptoms the second they feel them, and to get help right away if they don't improve.
So what's the big takeaway here? It's this. Giving a dose of intermediate-acting insulin is never just a task you check off a list. It's a really complex process where your clinical knowledge and your constant vigilance are what transform a routine medication into safe, effective, life-sustaining care.
So let's leave you with a clinical scenario to really make this stick. It's 9 p.m. You've just given your patient their evening dose of NPH. You know the peak could hit anytime between 1 a.m. and 9 a.m. overnight. What's your plan? What assessments are you going to make? What are you going to have ready at the bedside? Answering that question, now that's the mark of a truly proactive and safe nurse.